So again, my name is Catherine Abalos. I'll just give you a quick background on myself. So I have been a nurse for about 19 years now, and I actually was a nurse manager for about 15 or so years before I ended up transitioning into IT. So my current title right now is Director of Clinical Informatics, as well as Epic Training over at Scripps Health. So with that said, let's kind of talk quickly about my transition and kind of what led me to go into IT. So again, like I said, I was a nurse manager at Scripps Health, and what we did is we went live with Epic about two and a half years ago, and that's literally what pushed me into moving into the IT. And the reason being is because when we went live with Epic, there was such huge change for us, and that collaboration between operations and IT, honestly, at that point, was just not where it needed to be at that time. So with that transition with Epic, I actually reached out as a nurse manager at the time, reached out to IT, and Clark was there and said, can I join your team? Can I be that nurse that joins with the IT, collaborates with them, with us, so that we could work together to better support our patients as well as our nurses? And they said, absolutely, and that's why I'm here today. So with that said, I do want to let you know that, let me just log in. We have 3 great panelists here. 2 of them are inpatient, and actually my colleagues previously. So we have Caroline Sanchez, who is our Senior Director over at Scripps Health. Cynthia Lagmay, who is also at Scripps Health and is one of our nurse managers there. And then Karen Kennedy, hopefully you recognize her, actually recognize her name. She is your president-elect for HIMSS. Okay, so when we talk about patient experience, it's a different focus, right? In the past, we've always heard about patient satisfaction. It's always been about patient satisfaction. We have these patient satisfaction scores, and that's kind of just, I would say, the concern as we move towards patient experience, right? So our focus has always been on patient satisfaction. Patient experience and patient satisfaction are completely 2 different things, right? So when you think about patient satisfaction and kind of the direction we're going now, we need to understand what makes them satisfied. And that's where patient experience comes in, right? We need to understand what their expectations are, what they expect their experience to be before we could actually satisfy their needs. So that's definitely the focus that we've been heading towards. And in regards to IT and technology, a lot of that focus has been more on self-directed learning or self-directed care for our patients, and kind of a little bit more on the outpatient side. So being able to schedule timely visits and being able to communicate with their providers easier. So that's definitely been our focus as well. But the reason why I'm really excited about this panel is that at least 2 of them, and Karen as well, they're inpatient, right? So they have a lot of inpatient experience. So it's just another avenue that I think that I'm really looking forward to hearing their thoughts on. So let's go ahead and get started. Again, I'm going to ask that Cynthia, Caroline, and Karen go ahead and introduce themselves and then talk about just what does patient experience mean to them, what have they done within their organizations, and then we'll just see where that goes. All right, Caroline, you want to start?
Sure. I'm Caroline Sanchez. I've been in nursing for a long time. I'll just put it that way. I started as an ICU nurse. Sure. How's that? Is that better? Okay. Been in nursing for my whole career. But the wonderful thing about nursing is you can do a lot of different things. So I started out in the ICU as a bedside nurse, and then did management, did some education, and then moved into the biotech industry and was product manager for all of the Swan-Ganz catheters. So that was great. I got to see the medical device side of things, worked on interfaces for a new device that we had, and did a lot of user interface testing for that product. That was really exciting. And then I came down to San Diego for a small startup company that had a fabulous product, but tried to go live right in the middle of the dot-com boom. So that didn't really end up becoming a product that was live. So that was a difficult experience, but also very realistic. Then I had kids, so I went back to the bedside, and now have moved up into, now I'm the senior director. So I have responsibility of all of nursing, case management, rehab, and respiratory therapy at Scripps Green. So one of our big, motivations, and if we didn't have patients, we wouldn't have a business. So we always try to put patients first, and that's kind of our focus in as far as our strategy for Scripps Health as a whole. So that's just a little bit about me. Cynthia.
Hi, my name is Cynthia Lagmay. I'm a nurse manager at Scripps Green as well. My whole career has been nursing as well. I've been a nurse for 19 years. Started at the bedside and also did a lot of registry, so I've seen a lot of the San Diego healthcare systems. I've done a lot of unit leadership, and I'm relatively a new manager, almost 2 years, and I'm also Green's representative for our Patient Experience Council that's system-wide. So our new initiative, and we can talk about it more later, is model care. So it's, again, being patient-focused and what are the needs of the patient.
Thanks. So, good morning. Most of you met me or have heard from me previously. I'm Karen Kennedy, the incoming president for Southern California HIMSS. My background, like I said, is in nursing. But if you want to go way back, and I mean way back, I started my career growing up in New York City, and I went to FIT, Fashion Institute of Technology. So I do have an associate's in fashion buying and merchandising. So if you want any tips, or you want to comment on my hot pink shoes and hot pink nails today, feel free. And my background is also marketing business management. So I got my business degree, worked in business. I actually repped lines with a representative in New York City. And what that means is if you're a designer and you're small and you don't have enough money to have your own showroom, you would come and see myself and a partner, and we would have 3 or 4 different lines, and we would represent you in one big showroom, and I would give each of the clients enough time to meet and then show their lines. If you did pants, I can pair you with Mary who does shirts and show the line all together. So I've been marketing and sales for a long time. And then my sister, who I lived with in Manhattan, got married and moved to Australia. And I said, oh, she's a nurse and she's going to be working as a nurse in Australia. Maybe I should look back into this nursing thing. And my mom's a nurse, and I said, all right. So I looked into nursing, and I was like, I'm not really into the blood and gore stuff, But she's like, no, Karen, there's a lot more, and there's other areas. And I said, sure, I'll try it. And I thought I was literally going to be the nurse that would put the chart in the door, pull the sheets down, and go, the doctor will be right with you. But I wasn't. I became fresh out of nursing school. I went to school in New Jersey, to University of Medicine and Dentistry, UMDNJ. So I worked with a lot of physicians, and I worked at Robert Wood as a nursing assistant. And then I became out of school. I know for those clinicians in the room, you're not supposed to go into, especially when you first graduate, you gotta, go into like adult cardiac first or med surg. But I had a wonderful mentor, and I started and went straight into pediatrics and ICU trauma. So I was that nurse, gowned up yellow, running out to the heliport to pick up the kids from traumas and dealing with families. And so it gives me a different light, where sometimes in business I've learned a lot, and in nursing I've learned a different busyness, and I differentiate things between, is it drama or trauma, and I kind of get through my day. So, and I think that foundation has helped me throughout my IT career, which I spoke a little bit about previously, where I was with Kaiser. I started as a project manager to implement Epic. I worked at community health systems, and I traveled everywhere. So every state in the U.S. and community health system owns or operates over 200 plus hospitals, and I think I've been everywhere except for maybe Wyoming. But they did have a Jackson Hole, Wyoming burger place in New York, so maybe that kind of can count a little bit. But I've implemented every small homegrown for meaningful use initiatives, along with large Cerner and Epic and McKesson. I've been to all the campuses and have met just about every executive that there is on those boards and panels to kind of preach my mantra to keep us, the healthcare clinicians, at the forefront of health IT.
Thank you. So Caroline and Cynthia, you are part of an organization that has a fairly robust patient experience program. It's led by a physician leader, and it's enterprise-wide, consisting of 5 hospitals as well as over 35 or so clinics. So can you speak to some of those initiatives that you've been taking in regards to that patient experience program?
So when you think about patient experience, I want to start before answering her question directly, just talking a little bit about what patient experience means. Because I've been in healthcare for so long, patient experience has changed quite drastically because of who our patients are and because of the technology that they now have in their hands. If you talk to any patient, no matter how old they are, how young they are, or any patient's family member, typically you hear some level of fear. They have a fear of a diagnosis. They have fear of a lack of control. They have fear of painful procedures. They have fear of how long will this illness or injury last? How long will I be incapacitated? When will I go home? How will it affect my family? That hasn't changed over the years, but what has changed is how we give that information to them and the connectedness that we have to make between our patients and our staff. So you take somebody who, a normal, healthy person who's in control, who has a job, who's got a life, who maybe has some underlying fear, and then you put them in a hospital bed, you put a gown on them that opens in the back, and they can't even tie their own gown. You take away their devices, and you put them in a bed and say, don't get out of bed, or this bed alarm's going to go off. We've just heightened their fear and their anxiety, by many-fold, right? Most of what people need in that moment in time is as a connection. They need some compassion. They need someone they can trust. They need to know that what's happening around them is valid and the devices that work around them work. They need to know that the person working the device cares about them. They need to know that their experience and their moment in time is important. And I want to reference some work that you may have all heard about. Daniel Kahneman wrote a book a couple of years ago. He's now a Nobel Prize psychologist and economist. Interesting combination. But he wrote a book called Thinking Fast and Slow. And in it, he talks about 2 types of self. He talks about the experiencing self and the remembering self. And this is important when we talk about patient experience. Because patient experience, the way we measure patient experience is through a Press-Ganey survey. If you're at Scripps, if you're an inpatient, you get a paper survey. If you're an outpatient, you get an electronic survey. We're relying on getting measurements of patient experience back based on these surveys. And that's how we measure patient experience. It's a national tool. Everyone has to use it. And there are penalties and fines if your scores aren't high enough, thanks to CMS. So now we're looking at strategies, we're looking at technology, we're looking at connecting with our patients based on scores that are really not about what that patient experienced, but what they remembered about their experience. So your experiencing self lasts about 3 seconds. So Clark just experienced a moment here when he walked by. That was his experiencing self. But his remembering self may remember that moment, they may not. In your lifetime, you have about 600 million experiencing moments. But what do you remember of those? The challenge with patient experience is it's not really patient experience, it's patient remembering. And the fascinating thing about his research was that there are 3 key things that happen that affect your remembering self. It's either a massive change in something that was a otherwise normal experience, or the ending of your experience, or what was the other one? The third one was any change. So at the change, a critical event, a significant moment, or the ending. And so if you think about those three elements that affect your remembering self, and then we try to affect patient experience, we have to think about how that happens. So for example, one of the things they did was, if you go on a 1-week vacation or a 2-week vacation, you would think, well, if you went on a 2-week vacation, you'd have twice as good of a memory of that vacation as a 1-week vacation. Not really. But if you have a vacation where, you had a horrible flight home, you're going to remember mostly that horrible flight home. You may not remember the great flight there. So how does that airline look to you at the end of your vacation? We have to look at the patient experience in the same way. So if at the end of their stay, we're giving them a piece of paper with all of their instructions on it that is printed out of an electronic health record, and it doesn't make any sense, or it's a challenge, or the nurse says, I can't get this thing to print. This thing never prints, and they're delayed. Are they going to remember all of the great memories and moments that happened before that, or is that going to be the last thing they remember as they get wheeled out of the hospital? So patient experience is a really, really challenging thing for us in healthcare to affect. And I know we're going to talk, maybe there's going to be some specific questions, but how does your electronic health record affect patient experience? It can in a number of ways. If you're in the middle of a painful procedure and the nurse comes in to give you some pain medication, and she's got the scanner and she's trying to scan your armband so that she can give you your morphine, and she can't scan it in this thing, and I can't figure this out, and this device isn't scanning, and hold on, let me go get another device. And that's a patient experience event that, your electronic health, whether it's your the technology, the device you have, or the interface, or the connectivity, or the wireless, any of those things can affect your patient experience. So from the technology side of things, it's extremely, extremely important. And I'm going to let Cynthia now talk a little bit about how we at Scripps Health are trying to tackle the whole patient experience from a connectedness standpoint, connecting with our patients, not focusing so much on standing in front of a computer charting while I'm talking to my patient with my back to my patient, but how we are connecting with our patients and some of the initiatives that we have at Scripps that are called model care, putting the patient back in the center. You would think we always put the patient at the center, but because of just the constraints of doing more with less, sometimes we lose sight of the patient as the center. So talk a little bit about model care.
So model care is a relatively new initiative that we're starting here at Scripps, and it's exceptional care for every patient by every caregiver every time. So in order to get that, we've just starting in the inpatient units, we had to, how do you know something's wrong if you don't have a standard? So we had to kind of revamp and think, what's the nurse's job when a patient gets admitted daily, and then when they're discharged? And so we came up with the standards of care for all nurses throughout the system. So this is your recipe of how you take care of your patient. And what we see is a lot of things like technology, equipment, location, all those things can kind of get in the way of the nurse being able to take care of the patient and spend that time with the patient. So model care is also about us figuring that out for our staff. Like as a nurse leader, I'm listening to my staff, and these are what we consider defects, and it's preventing me from admitting this patient. It's preventing me from getting them to their MRI, etc. So we collect those defects and we track them, and we try to see what can we do to fix those things and take those distractions away from the nurse so that they can spend that time at the bedside with the patient. We've also, and in that we have a management system. So I report to Caroline. So any of the defects that I can't, take care of for my staff, I elevate them to Caroline. And if it has to do with other departments that don't report at our tier 3, then I report those to her as well. And I'll let Caroline talk a little bit about the tier 3 because we're really proud of our tier 3 process.
So when we talk about tiers, the tier 0, if you will, is that front-facing, patient-facing person, whether it be a tech, a nurse, someone drawing blood on that patient. That's that patient-facing person. If they see that there's a problem or an issue related to what we consider a standard, then they will let the tier 1 or say the charge nurse or supervisor know. If they can't resolve it, that if they can't just do a quick troubleshooting, then they'll elevate it to tier 2, which is Cynthia. And if she then can't resolve it, she'll elevate it to me. We have a process every day. We have all of the different managers of all the different departments come together and review all these defects. We also have IS there. So if there's any device-related issues, they come. And she comes once a week, actually, because we don't have that many, so she doesn't need to be there every day. But then we talk through all of these defects. Some of them are easy to solve, and you can fix them quickly. Others really take a little bit more work and time and energy. But unless we're continuing to address and resolve these issues, the patient really does feel those effects, and the patient does, that patient experience tends to be affected. So it's been a really exciting process for us to put that patient back at the center. One example, and this sounds crazy, but it's pretty realistic. It doesn't really have to do with technology, but I'll tell you anyway because it's kind of funny. We had a defect that just kept coming up over and over again. We didn't have enough pillows. Now you would think a hospital, a system the size of Scripps would be able to have a pillow for you when you arrive in your hospital room, right? You would think. Why can we not have enough pillows at the right place at the right time? So we thought, well, we'll just go next door and get a pillow from the room next door. Well, that's kind of that type 1 troubleshooting, just, run back, fix the problem, right? Well, I didn't really fix the problem. I got a pillow for the patient, and there was a little bit of a delay, but yeah, I didn't really fix the problem. So then we said, well, we'll just deliver more pillows. Okay, well, that's kind of another solution, but where did you get those pillows from that you're now delivering to this unit? Well, you got them from the OR. Well, now the OR doesn't have enough pillows. Well, so maybe we need to find out where our pillows are going. So we actually had to spend quite a bit of time following the life cycle of a pillow to figure out what was happening with these pillows. I mean, it was crazy. But you think about it, unless you're looking at problems from the patient's perspective, maybe you're just going to put a Band-Aid on it and think you fixed it and move on. But the OR patients need pillows, the floor patients need pillows, the procedural patients need pillows, everybody needs pillows. And unless you bring all those different disciplines together and really try to figure out where our pillows are going, you're never going to fix the problem. So it's just a small example of a kind of a fun problem, and now it's a little bit of a joke. We call it the pillow par, and just the other day, we actually solved this in January. Just the other day, somebody reported that they didn't have enough pillows. We're like, wait, we fixed that problem. It was just a new person that didn't know the process, so that was an easy thing to fix. So that's kind of one of the fun examples that we have. Do you want to go to some questions?
Sure. I'm going to reach out to Karen. So Karen, so I know we actually spoke very briefly, similar to what Caroline spoke to earlier about patient experience and how that's evolved. So do you have thoughts on that and maybe just experiences again on initiatives that you've seen?
Yeah, thank you. I love everything that you both have just said. It rings true to my ears and true to my heart. One of the things that you touched on was when you spoke of experience is keeping the patient in control. And you lose that control, you feel out of sorts. I've been a patient, I've had loved ones that were patients, and coming from a technology side, when I do consulting for technical firms that are in have great ideas and innovation, but they're missing that clinical piece. And one of the folks that I used to work with was Tiger Text, and one of their CTOs branched off into a company called Ava, and which is I think Ross was talking about that, where he mentioned you're going to ask, your Amazon.echo for something. And I'm famous for that. I walk around, and even wherever I'm at, I want to know what time it is. I know I can look on my phone, but I want to ask my room what time it is. And I set 2 different timers, one for the baked potatoes, one for the steak, and set a timer for the grill to go off. And you can do that all by just, saying it. And this company, he's actually developed a product called Ava. And what Ava does is just exactly what you would think. It sits on your bedside. It's like chained to the side of the bed on a little nightstand, like glued down, like you would want to have it in your hotel room and go, what time is it? Set me an alarm. And it actually routes to, for example, dietary. And those are the types of things that, as a clinician, I'm working with technology folks to identify how does that translate, and what are the types of things that patients are asking for when they ring the call bell. It's their IV. Is it something that the nurse needs? So it will automatically message to the nurse's phone or whatever their device that they're carrying, versus I'm thirsty, and then it will go towards a nursing assistant's phone instead, or the technician. We talk about diet, and we know that one of the biggest complaints in a hospital is the food tastes horrible here, and I don't get what I want, and I'm hungry now. It's 24 hours a day our patients are being admitted, but the kitchen's only open and serving food till 7 p.m. And so then you get a cold sandwich in the fridge. How do you kind of, manage those pieces of it? What if the patient's NPO, nothing to eat by mouth? How do we manage those types of situations? And the technology has improved so much that it's interfaced with your EHR. The patient asks for something. It says, oh, I'm sorry, Mr. Jones. Your orders are nothing to eat by mouth right now due to your upcoming surgery. I will notify your nurse of your request. And so those are the types of things that I'm writing to put into that information for the clinicians to use. So even though it's heavily IT, and I don't necessarily have to know everything about HL7 interface and how that is going to be the communication device, which sadly I kind of do know, but it's having that voice to understand that, keeping that patient in control, and that's some of the technology that's out there that does that. So I think that that's a great experience that you spoke about. And you mentioned looking at the computer versus looking at the patient. And I can't tell you, that was like the bane of my existence. In clinical informatics, we talk a lot about the ergonomics of pieces, right? So where is the computer in the room? And when I was an informatics nurse at Scripps, I was the ones that would kind of go in, and we would have a model room. And the room was so small. I'm like, so where does the nurse stand, and where does in comparison to the patient? And so on the walls, we have oxygen and suction, and how does that ergonomically fit into the room? And as we became from our rooms of double occupancy to single occupancy, how does that look? So those are the types of things that helps the clinician to look at the patient and be centered, because you want to have that experience of a positive. And at the end of one of the things that we speak about with experience is not just handing them that piece of paper when they're walking out the door, but talking to them about the experience each time. When I was a nurse educator, I used to work at CHOC Children's Hospital in Orange County, and I was their clinical educator for 3 or 4 years. And I started the program there, and I said, one of the things that I learned was behaviorally, if you keep saying the same thing, when they read it, they'll remember it. So sometimes it's maybe even not even a technology piece. Each morning, how was your experience last night? Oh, was it good? Oh, that was a good experience. Was there anything about your experience that we can improve? Oh, thank you. Your experience was great regarding this, because the hospitals started mimicking almost the similar aspect of a hotel. And we hate to say it that way in some ways, but it's the same process where whenever you see someone, you're always engaging that patient. If I'm in a hall and I'm suited up because I'm with a client heading in and I see a patient, sometimes as non-clinical folks, we tend not to look at them because we may feel embarrassed for ourselves or for them. They're not in their right clothes. But it's okay to look at somebody, even if they're in their gown, and going by and smile and say hi. Because each time that you're a guest in that hospital, you could be a patient in that bed as well, and you're contributing to the experience of the patient. So whether you're technical or you're clinical or you're just passing through or you're volunteering, I can't tell you how important it is to look at somebody and see them as a whole person, and not that person in a bed that's sick with tubings, and smile and say good morning or nod, it's okay, and keep going. It's part of that patient experience that I think we hold true as human beings, whether we're in IT versus clinical.
Thank you.